Hello, everyone. It's a pleasure to be standing up here and to talk about two cases of patients who were diagnosed and treated for venous malformations using sclerotherapy, who then returned with refractory pain and were treated with cryoablation. So I have no financial disclosures or any other conflicts of interest to disclose, unfortunately. But I do want to thank and acknowledge my colleagues at Stanford, many of whom are here today, who have been instrumental to the success of the vascular anomalies clinic there, and who have been very supportive of me when I joined, and of course for the Boston Children's Group, who taught me so much about vascular anomalies. And now that I've successfully tied a whole cohort of people with me should this presentation bomb, I will proceed to present my two cases. So the first patient is a 23-year-old female who presented to Stanford back in 2024 with recurrent pain of a venous malformation of the right posterior thigh. So she was originally diagnosed at an outside hospital with a hemangioma around birth, which was surgically excised. In December of 2014, that's 10 years before I saw her, she presented with pain and increased growth of a vascular lesion that would oftentimes wake her up at night or when she changes positions and exercise. So this was initially managed with aspirin and compression, and in 2015 it was sclerosed with STS, and then again in 2017. So unfortunately, I don't have any tissue sampling or genetic testing for this patient. So here are some images from when she first presented in 2014. This is a T1 non-fat saturated sequence, which is always important to obtain for patients with vascular anomalies. As you can see, there's very scant fat signal around a T1 isointense lesion. Here you see T2 fluid-sensitive fat-saturated sequences showing a T2 hyperintense lesion intramuscularly with black hypointense foci, which is compatible with a sleepless. And on T1 fat-fat post-contrast imaging, you see some scant internal enhancement. So here's an image of the intraoperative sclerotherapy that was performed. You can see it was accessed very successfully with angiocap, and you can see treatment agent covering successfully this lesion. So interval history, when she was initially treated in 2015 with percutaneous sclerotherapy, she had good short-term response. However, in 2017, she presented with recurrent pain, and sclerotherapy was repeated. When I saw her in 2024 in VAC, she had obtained some new outside imaging and again presented with recurrent pain. So I referred her to myself for cryoablation with reported symptomatic relief. So here's the 2024 outside MRI, T1 weighted sequence. You can see compared with the 2014 MRI, there's a lot more prominent fat signal around the vascular lesion, marked by the asterisk. Here again, you can see phlebliths on the T2 fat-fat images. And then this was a much better post-contrast image showing near homogeneous internal enhancement of the vascular component. Luckily, because this was an outside hospital, they ended up getting a CT. So we have CT images of this lesion that shows this sort of very obvious fat component peripherally with hyperdense foci compatible with phlebliths. Here's some ultrasound images obtained during my cryoablation with initial and then once the ice ball started forming. And I think this is one of the advantages with doing cryoablation for soft tissue vascular anomalies, is that you can watch the ice ball with ultrasound. And oftentimes I like to pair it with cone beam CT, which allows me to map the trajectory of my probe positioning as well as be able to map the predicted ice ball formation. Patient number 2, 11-year-old female who has left arm pain, presented to Stanford's multidisciplinary VAC. She had sclerotherapy in 2022, and then returned to VAC clinic in 2024 with recurrent pain. So then in late 2024, I performed cryoablation for her with good response, and once again, unfortunately, I did not obtain any tissue biopsy or genetic testing for her. So here we have T1 non-fat saturated MRI images showing a vascular lesion intramuscularly with some fat signal. And you can argue, based on the T2 fat saturated images, that this could be a phlebitic type venous malformation with phlebus, as marked by the orange arrows. Here are ultrasound images. The top right image, or left, top left image shows the ultrasound that was obtained prior to sclerotherapy in 2022, and the intraoperative ultrasound obtained when I proceeded to do the sclerotherapy for her. You can see that after the initial sclerotherapy, we've lost a lot of the vascular signals, and you can see the echogenic focus, which is a phlebus marked by the orange arrow. So intraoperative sclerotherapy images showing good lesional coverage, and then intraoperative ultrasound images for the cryoablation showing probe positioning, the formation of the ice ball, cone beam CT for trajectory planning and mapping, as well as sort of the final size of the ice ball formed in this lesion. So some points of discussion. Originally, for these lesions, which still even now I would argue are more likely to be venous malformations if you were just to look at it from an imaging standpoint alone, with the compressible slow flow intravascular vascular signals, as well as phlebus, that sclerotherapy is not being, as the primary treatment, is not wrong to have been performed. Some arguments for cryoablation after the patient presented with recurrent pain is the circumferential macroscopic fat signal seen on imaging, the relapsing pain despite sclerotherapy, as well as the fact that cryoablation has been shown to be effective in treating both FAVAs and venous malformations. So some of the advantages of using cryoablation is that it's has a natural analgesic effect. You can localize the treatment area, and although some of the potential drawbacks is you do risk damaging the nerves, and if not well done, you can risk having hypothermic injury to the skin.
Okay, I think you have to conclude now.
Oh, sorry. So to conclude, I like to say that the appearance of phlebus might not necessarily guarantee a diagnosis of venous malformation. Cryoablation should be considered for refractory VMs that are resistant to sclerotherapy, and that there might be advantages to always obtaining a soft tissue sampling when you're doing repeat treatments. And thank you.
So we do have time for 2 or 3 short comments or questions from the audience.
Can we have the poll questions on the screen in the meantime, please? I just have one question for the first case you presented. Which were your main criteria to call this a FAVA? Was it radiological criteria or mainly because they did not respond to sclerotherapy?
I think it's a combination of several symptoms, several factors. One is the recurrent pain, the nature of the pain, which was more of a sort of a constant, frequent in nature rather than followed by certain exercises or certain instances of trauma. 2 was the sort of prominent fat signal seen on imaging, and 3 was the refractory pain despite sclerotherapy.
Thank you.
Michel Gossef from Paris. Don't you think the appearance of fat after the first sclerotherapy could be due to the sclerotherapy as a reaction of the peripheral tissue more than indicating a FAVA?
I think certainly. I think that certainly can be as a result of sclerotherapy, or just a result of the normal progression of disease over the course of 10 years. However, because there are certain things that suggest this may still be a fava, even though it's more likely this was a venous malformation. Cryoablation, I thought, would be the better choice because of the recurrent pain and the resistance to sclerotherapy.
One last question.
So I agree with the first case. I think this is Stacey Bass from Yale. I think that probably was a venous malformation that you treated. But to Anne-Marie's point, does it really matter how you treat them versus treating the actual symptom? Favas can have thrombophlebitic pain. They can have phleboliths. So is their pain thrombophlebitic pain or is it nerve pain? Choose your modality based on the type of pain they have. I have lots of patients that I've done sclerotherapy on because they have that classic thrombophlebitic pain. They're good for a couple of years. They come back with a shooting nerve pain down the limb, down the arm. So I would say to this group, perhaps we should be treating the symptoms, as we've all discussed in other sessions as well, and not necessarily just the appearance on MRI.
Yeah, thank you. I think you really hit the nail on the head with that comment. With cryotherapy is great treatment for pain. And
Perfect. Thank you very much. We will go on to the next presentation. I will ask Dr. Dario Tepliski from Argentina to come and give his presentation about radiofrequency ablation.